this is Dr. Pruett again. We're here with more educational content. Today's topic is fairly serious and a little bit heavy, but it's incredibly important for EMS providers to be ready to recognize signs and symptoms of patients who are being abused. Child abuse is unfortunately a pretty large epidemic in our country. 75% of these children are victims of neglect, so it's not always physical abuse, which is important to realize, but the majority of the abuse comes from parents. And unfortunately, a lot of children die every year as a result of this. And if you look at New Mexico, I'm sure it's no surprise that we top the list in terms of child maltreatment. And our actual numbers for child fatality have doubled over the last 5 years. If you look at New Mexico as a whole, this is a large problem in the rural areas, but it's especially a big problem in Bernalillo County, right where we're located. Our most vulnerable patients, of course, are the ones that have a difficult time speaking up for themselves. So the very, very young, the very, very old, and our special needs populations. These are the patients that we need to have a high degree of suspicion for abuse and maltreatment, and recognize situations and report them when they just don't feel right. We're in a really unique position to be advocates for these patients who are in a very vulnerable population. Most of the children who are victims of abuse and unfortunately victims of fatalities are actually younger than 3. And usually these patients have suffered neglect prior to the physical abuse that ultimately is the cause for their mortality. Many times it is the patient's parents who are the perpetrators. It's important for us as we go into these home environments and actually see the interactions between parents and children or patients and their healthcare providers to realize that we get to see and hear and smell and experience things that won't be experienced in the hospital. So if something doesn't seem right, it's incredibly important to maintain your situational awareness and have a low threshold to report that and advocate for your patients if you need to. Now, the technical definition of abuse, it can either be physical, sexual, or emotional. And neglect is a type of abuse too. Basically, that's where the careholder is withholding basic physical or emotional needs. And that can be anything from food or housing or clothing or even medications. Those are able to be prosecuted under the law. Now, clues to abuse that you can look for would be unexplained injuries or stories that just don't make sense. If you have a patient who is making excuses for accidents that don't seem to add up, or if there's signs of neglect or delays in treatment or care. It's on us to be suspicious, knowing that our rates of child abuse and elder abuse are very high in the city. Medical providers are actually the primary reporters in child abuse in children less than 5 who can't speak up for themselves. And so we are in these homes, we are in these situations, and it's on us to be their primary advocates if they're in a dangerous situation. Just like any patient population, you want to approach the patient and assess the ABCs. Especially important in these vulnerable populations is to expose the patient. So maybe when you're listening to breath sounds, lift up the shirt, look at the back. When you're examining the stomach, look at the stomach. See if you see bruising in places that are hidden where people normally wouldn't look, because a lot of times these abusers are very tricky and the patients will be covered. Another important thing to consider, especially when you're assessing pediatrics, is to just have a couple anchors for your milestones. I don't expect everybody to have this chart memorized. And of course, there's a wide variety of normal in any childhood development. But in my mind, what I try to do is pick about 3 things that I can remember that a child should be doing at a certain age, give or take a month. And that'll help assess when the parents tell you about injury problems. So the 3 that I pick and that I can remember pretty easily are that a 2-month-old cannot be rolling over, but should be about the age where they can raise their head up by themselves. About 5 or 6 months is where they start to roll over, and about 10 months is where they start to pull themselves up. So if you have a parent that tells you that their 3-month-old rolled off the bed, I would say that that's an inconsistent story. Just as if you had a parent that told you their 10-month-old had tried to walk down the stairs and fell and hit their head. That story doesn't make a lot of sense to me. Now, certainly there might be 7 months old that can roll down the stairs, but try to pick a couple of milestones that you remember and weigh the parent's story and the injury pattern against what you know that a normal infant should be able to do. Skin findings are going to be your most common clue to any kind of abusive injury, whether that's bruises or burns or bites or abrasions. Any kind of bruise, as you know just from experience, results from blunt force. And it's important to ask where and why that blunt force occurred. There's certain bruising patterns that you can look for in children that are more suggestive of abuse than others. But in general, when you're looking at any bruise, you want to consider the child's developmental ability, the location of the bruising, and the shape and the pattern, and how many there are and what color they are. So any bruising in a non-mobile child is suspicious until proven otherwise. So we just talked about 6-month-olds can roll over, but they can't walk or pull up. So really, children less than a year shouldn't have many mobility type bruises. Also, if you see bruises away from bony prominences like on the back or the buttocks, especially on the face or the neck or the ears, anywhere on the trunk. It's one thing to have bruises on the knees and the elbows from falling down on the extensor surfaces, but it's an entirely different story if you have bruises on areas that don't necessarily impact the ground from a fall. If you see multiple bruises in clusters, if you see linear bruises that look like they come from a patterned object, or if the bruises are large, or especially if they're associated with petechiae around the edges. And what petechiae are is just burst capillaries around the edges of a bruise. They're basically little tiny pinpoint hemorrhages that result from a large blunt force, so much so that the capillaries burst. And usually that's due to venous pressure. So it can happen medically, like if someone's coughing a lot or there's some sort of strangulation injury or something that's building up a lot of force, even vomiting, a lot can do it. But likely if there's a bruise associated with petechiae, that's from a pretty severe blow and needs to have a high degree of suspicion for where that blow originated from. Studies have shown that suspicious bruising can be related to underlying fractures, so that's why we're examining the skin, exposing our patients, and if you see suspicious bruising patterns, have a high degree of suspicion for other underlying injuries, especially in your patients that can't communicate with you. So infants, maybe if they have inconsolable crying and you see concerning bruising, you can worry about underlying brain injury or even abdominal organ injury or fractures as well. So once you see those bruises that you know to look for, you can consider other deeper injuries. There's an easy rule to remember when you're thinking about abusive injuries. You want to look at the torso, ear, and neck in children less than 4. This is called the 10-4 rule. And you're looking at the location and the age. So ears, neck, torso bruising is never normal, and in children less than 4 especially. And any bruising in a child less than 4 months is not normal either. Abdominal bruising can suggest much deeper injuries, liver lacerations, bowel injuries, even retroperitoneal injuries. If you see bruising on the abdomen, you need to be very concerned for underlying severe solid organ or hollow organ injuries. And then look for patterns as well. So whether it's belt loops or a handprint, if you see a pattern, that is never normal. And severe bruising on the buttocks is not normal either. Special needs children are also very high risk for abuse. Now realize that special needs children, depending on their behaviors, they can have some self-abusive behaviors and be throwing themselves against objects or acting out, and might have some bruising patterns based on their behavior. But really, if you see abdominal bruising or bruising on those soft tissue areas that aren't on extensor surfaces, I would have a high degree of suspicion for possible caretaker involvement until it's explained otherwise. Again, here's some more patterns that are unfortunately very common and you might need to recognize, but this is what a cigarette lighter burn looks like on a patient's abdomen. When you're getting your patient history, things you need to watch out for in the history would be what's termed as a magical burn, or the caretaker saying, I don't know, it just appeared overnight. Things like that don't just happen. If there's an inconsistent story, or if you know your developmental milestones and things just don't add up, it's up to us to have a high degree of suspicion. Burns, unfortunately, also are fairly common forms of abuse, whether it's submersion injury, usually in hot water, or with cigarettes or lighters. Usually this will be bilateral and frequently involves the genitals. Realizing that when we are looking for bruising, there can be some normal or acceptable skin change patterns. Sometimes with cultural healing traditions, whether that's cupping or coining, you might see patients with skin changes related to that. So if you see them, they're pretty typical. The cupping is just circular bruises, usually along the spine. And then coining it looks more like abrasions where coins have been rubbed, again, usually along the spine. There's also certain birthmark patterns in patients with darker skin color, and it's just a collection of melanocytes, usually right over the top of the buttocks, and that can be normal as well. In that patient where you see that, you might just ask how long that's been there and if the patient has had it since birth. Now, fractures, if you've got a uncontrollable crying, say in a toddler or a patient less than 18 months, they could have an underlying fracture and they're not always obvious. So consider the story in light of what you know a patient should be able to do developmentally. Concerning findings would be if you're called to a patient that's not breathing correctly, if you see bruising, that 10-4 bruising, so torso, ear, or neck bruising in a patient less than 4, or any of those signs in a patient less than 4 months. Signs or symptoms of a skull fracture or severe head injury would be a bulging fontanelle. If you have a seizing patient or a patient that's profusely vomiting with any altered mental status or poor muscle tone, have a high degree of suspicion in your youngest patients for possible abusive injury. So if we think about a possible call for us, if you're called to a 2-year-old male seizure call, say it's the fall and you're thinking it's likely a febrile seizure, you get there and the patient has a heart rate of 130, SATs 91, sugar's normal, no temp though, maybe 100, but he's breathing irregularly and he's continuing to seize, and you're eventually going to have to bag this kid. If nothing else is adding up, have a high degree of suspicion in this child with altered mental status and seizures that he's got a underlying brain injury from likely trauma that could be non-accidental. Another fairly common case would be a 3-month-old who's just not breathing normally, and you get there and truly the patient is not breathing normal and is completely unresponsive with relatively normal vital signs. This is a patient where you want to do a really good physical exam and have high degree of suspicion for severe head injury due to non-accidental trauma. Children aren't the only ones at risk for abuse. As the population is aging, our elder population, especially with dementia, are at incredibly increased risk of abuse and neglect as well. And it's not always physical. It can be emotional or medical or even verbal. Risk factors for elder abuse would be social isolation, patients with dementia, again, patients that can't advocate for themselves or maybe remember or understand what's happening to them, or if they're in a shared living arrangement with their abuser. Typically, abuser characteristics will be caretakers with a history of mental illness or some sort of substance abuse or dependency, usually financial, on the older adult. Nursing homes, there's more and more reports of nursing homes that have complaints about abuse and neglect in them as well. Things that you can look for as you're called to these nursing homes. I know we go there frequently, but remember that these patients are some of our most vulnerable. So if you see that they have poor hygiene, if they're sitting in their urine or stool for a long time and have skin breakdown from that, if they're malnourished, or if you suspect that they're not getting the medication that they need or it's being misused, it's on us to report that. For adults, the way to report that would be through the Adult Protective Services. This is through the Aging and Long-Term Services here, or you can contact your supervisor to help you figure out how to do a APS report. If you recognize it, if you're not going through APS and you do have high degree of suspicion, we are mandatory reporters through the state. Easiest way to do this is through police. If you have a suspicion of any kind of abuse, get the police involved quickly. Also, make sure you report your concerns to the hospital when you get there, whether it's Children's Hospital for peds or the adult hospital for your other patients, and then also involve Adult Protective Services as well. Remember, it's good to have situational awareness and a high degree of suspicion, but it's not up to you to fix the problem right there. So try to have as much self-control as you can. As emotionally charged as some of these scenes can be, try not to outwardly provoke the abuser or accuse them until you've just gathered some data and done your reporting. Documentation is incredibly important in these instances. Things you want to do that I've found helpful over the years is make sure try to stay as objective as possible is the number one goal. But when you're stating in your patient history what happened, all you need to do is report what you were told. And it's easiest to do that by just using quotation marks. So, for instance, mom reports or caretaker reports, and then just verbatim record their sentence so that it's exactly what they told you and you don't have to insert any of your own dialogue. Where you can insert what you see and what you hear and what you smell is in your physical exam, and that's just objectively reporting what you see, trying to avoid judgments, and being as descriptive as possible. Now, if there's concerns for sexual abuse on a scene, again, when you're documenting, make sure you're using quotations of exactly what you're told. And then really, unless the patient is unstable, you need to do a very limited physical exam. I wouldn't expose these patients any more than you need to. They're going to be examined at the hospital. If they're stable, I would just ask them if it's okay if you take their vitals. Try to empower them as much as you can if they've just been violated. Give them as much authority as you can. Ask them if it's okay before you touch them. Respectfully talk to them. And again, you don't need to do a very thorough physical exam. That'll happen at the hospital. Okay, well, that's all I have for abuse. I know it's a heavy topic, but we have a key role in protecting these patients. So get out there and be good patient advocates.